of insulin for the treatment of diabetic patients. And we have all this great variety of drugs, but also we have the greatest number of diabetic patients since ever. And with all this variety acting in different sites and have different mechanisms of action, we are in a position that we can say that we can fight hyperglycemia effectively, but we aren't. This is a chart we are all familiar with, other guidelines for the pharmacologic treatment of type 2 diabetes patients. But what is more important than the exact combination of drugs is a person-centered glycemic management, and the final goal is to prevent complications and optimize quality of life of our patients. And how to do so? First of all, it is important to calculate cardiovascular risk. European Society of Cardiology suggests us to use score 2, which is a new model to estimate the 10-year risk of cardiovascular disease in Europe, which is sex-specific and available for 4 distinct European risk regions. This score is for patients under the age of 70. There's 2 modifications. One, the score 2 OP for older persons, and score 2 diabetes, especially for diabetic persons. This is easily downloadable in our mobile phones. And if we want to see an example, if we take the 2 separate patients, one female and one male, which is in the same age, both smokers that have similar measurements of blood pressure and lipid levels, we will see that the female patient living in a moderate risk region has around 5% risk, while the female patient in the same region has 7.5% risk. And if we take the same person, if he's living in a low-risk country, the danger is about 6% and more than double if he were living in a very high-risk region. Yesterday, this is not diabetic patients. Yesterday, out of curiosity, I ran the algorithm for a female diabetic person, well controlled with HbA1c around 6 and 10-year duration of diabetes. And this risk in a moderate risk country raised up to 11. And of course, Greece is now a moderate risk country. After that, we're going to set glycemic and weight goals and find out any other risk factor. And it's important to remember that when we fight diabetes, we must fight for the other risk factors that raise the total cardiovascular risk. Finally, we're going to check for other comorbidities. And hopefully, we're gonna come with a plan consists of both lifestyle management and pharmacologic treatment. As for the new ADA guidelines, there are some notable updates. They suggest to support a greater weight loss and a healthier way of living. We, as all know, have SGLT2s for preserved and reduced ejection fraction heart failure, and we have finerenone for diabetic patients with chronic kidney disease and albuminuria. When we can, the lower the best is for LDL in high-risk patients, and we have new cutoffs for the diagnosis of hypertension. When it comes to choose the right regimen, we have to take a lot of parameters under consideration, But our final goal is to optimize medication use and reduce treatment discontinuation. In this chart, we can see the commonly used drugs and benefits and side effects of them. And according to the latest Congress of European Society of Cardiology, a patient with known cardiovascular disease or at very high risk, based on the estimation via score 2 diabetes, there's a strong recommendation to use SGLT2 or GLP-1 receptor agonists. If we want additional glucose control, there are other options such as metformin. As for metformin, we have to keep in mind, of course, we have new novel drugs, but metformin is still an effective drug with beneficial effect on weight, maybe proven cardiovascular events decrease, and of course, it's safe and inexpensive. On the other hand, pioglitazone, even if it has a pleiotropic mechanism of actions, very attractive, such as it can lower blood pressure, it increases HDL, improves endothelial dysfunction, and decreases inflammation, although in clinical practice, it's not well recognized. The newest drugs, we are all familiar of these trials. In the first plot, we can see the trials with SGLT2s and outcomes for cardiovascular disease, and the second for all the trials for patients with heart failure. And it's now like a knowledge that SGLT2 inhibitors can reduce the risk of heart failure hospitalization, as long as, although they reduce cardiovascular and, of course, all-cause mortality. Same applies to GLP-1 agonists when it comes to cardiovascular disease events. This is cardiovascular death, myocardial infarction, and is the stroke, all in favor of, based on disease proven or in high risk, a patient with heart failure or chronic kidney disease, we should go, of course, with an agent with proven cardiorenal protection. If our main goal is weight management, we can choose between semaglutide and tirzepatide, which I suppose we can hear later for them in detail. And when we want an agent with very high efficacy, we can choose between some GLP-1, the combined GLP-1 tirzepatide, insulin, or combination therapy. Our traditional approach is a stepwise addition of medications to metformin. Although a few years later, the VERIFY trial, which started with initial combination of vidagliptin with metformin versus metformin, showed that initial combination, here is metformin with vidagliptin, is superior to metformin alone. And though these results cannot be generalized, it supports that maybe a more intensive early treatment has some benefits. Here we all know that in hypertension guidelines, the combination therapy is already in the guidelines. In dyslipidemia guidelines, maybe is the next that will be announced. And now we are waiting to see if something like that would apply to diabetes guidelines as well. So if we have to achieve a grade reduction, it seems reasonable to start with a combination therapy or a more potent glucose-lowering agent. And it's important to remember that this decision should not be delayed. And here is a meta-analysis that compared the effectiveness of the available drugs. In the first plot, we have drug-naive patients. Here in the middle, we can see metformin. Above it is more potent and less potent drugs. The most potent is subcutaneous semaglutide with least potent DPP-4. And in the second plot, we can see the results of the addition of these drugs to metformin. And again, subcutaneous semaglutide is the most potent, followed by other GLP-1s and insulins. And if we wonder GLP-1 or insulin, there's a lot of trials, compare them, and they all conclude in the same that GLP-1 maybe is the preferred option because GLP-1 has similar glycemic efficacy or maybe greater with lower risk of hypoglycemia and of course the beneficial effect on body weight with the cost of the few gastrointestinal side effects. Although insulin is being effective where other agents are not and has the benefit of it can be a part of any combination. It is reasonable to use insulin when we have very high glucose measurements or when we have symptoms or of a hyperglycemia or evidence of catabolism. And it's useful to remember that we can simplify the scheme when glucose toxicity resolves. Finally, finerenone. After the Fidelio and Figaro trial came the fidelity analysis. Λίγο πίσω. Okay. The fidelity analysis took patients and saw that the initiation of finerenone, irrespective of the use of SGLT2, has beneficial cardiorenal outcomes in cardiorenal spots. We can use finerenone when a patient has chronic kidney disease, type 2 diabetes, albuminuria, and an eGFR above 25, despite the treatment with RAS inhibitor. And if a patient is on finerenone, we can continue it since GFR drops to 15 in a dose adjustment with a adjusted dose and with our mind in the potassium serum. Here's a consensus of ADA and KDIGO, and the green boxes applies to type 2 diabetes patients. Blue boxes are for both type 2 and type 1. And apart from the general considerations, it suggests that the first step should be SGLT2 inhibitor if the GFR is above 20, or metformin if the GFR is above 30. And if we want additional therapy, we should use a GLP-1. Here is the addition of finerenone. And for chronic kidney disease, we can see in this chart that SGLT2 and GLP-1 has the most benefits with the lower adverse effects. So is the preferable drugs for these patients. I would like to thank you.